My name is Charles Facelis. I am the Assistant Chief of Medicine and Program Director at the VA Medical Center in Washington, D.C. and Associate Professor of Medicine at the George Washington University School of Medicine, and I will be discussing pulmonary medicine with you. The first chapter we will be talking about is the diagnostic tests, things to do to patients to make a diagnosis and follow up on treatment plans, and these are important tests that we will have to know for our USMLE. The first test that I'd like to talk about is the pulmonary function test. Now this is a very important test. Anytime we make a diagnosis on a patient concerning a pulmonary disease, we have to do pulmonary function tests for a couple of reasons that we're going to talk about. There are basically three reasons that we do pulmonary function tests. The first one is to differentiate between the two big different groups of diseases that affect the lung. The restrictive processes, like for example idiopathic pulmonary fibrosis, the pneumoconiosis, the occupational lung diseases like silicosis and asbestosis, they're called pneumoconiosis, and another 150, 200 diseases. All these diseases are called restrictive diseases because they involve the lung parenchyma and they cause restriction of lung volumes. And then we want to differentiate that from the other big group of diseases, the obstructive diseases, like asthma, like chronic obstructive lung disease, emphysema, and chronic bronchitis. So the first reason to do a pulmonary function test is to differentiate between these two groups of diseases. You could see that the differential diagnosis differs when you compare one disease versus the others. So if I'm going to see an obstructive pattern on the pulmonary function test, my differential diagnosis now is going to be, is it asthma? Is it chronic obstructive lung disease? If I see a restrictive pattern on the pulmonary function test, now I'm going to talk about different things. I'm going to say, what is their occupational exposure? Do they have some other type of disease like sarcoidosis, like idiopathic pulmonary fibrosis, totally different from obstructive diseases? The second thing that we do pulmonary function tests for is to assess severity of disease. A lot of patients with chronic lung diseases have to have surgical treatment. For example, a patient with chronic obstructive lung disease is a smoker and develops lung cancer. We cannot resect that lung cancer even if it is surgically resectable unless we prove on the pulmonary function test that the extent of this disease is not severe. So very important, pre-op evaluation of lung disease, pre-existing lung disease, in order to do lung surgery. We have to do pulmonary function tests. And they tell us, for example, we're going to talk about this a little bit later, that certain of the parameters have to be above 50% of predicted. For example, the FEV1 or the FVC has to be above 50% of predicted to be able to do adequate lung surgery in these patients, just to give you an example. And then the third scenario that we do pulmonary function tests is to do post-treatment evaluation. And what I mean by this is that you put a patient on certain medications. I want to bring this patient back about 2 months later. And when I ask them questions, clinical questions, they still complain of dyspnea. They still complain of shortness of breath and so forth. So I'm not going to be able to quantitate the difference in treatment. Did I make a difference? Is this patient getting better? The only way that I could see small differences that are not clinically evident is to do the pulmonary function test. So for example, I put a patient that has idiopathic pulmonary fibrosis on corticosteroids. I bring this patient back 2 months later. Their FEV1, let's say, was 20% of predicted. If this patient is starting to get better on steroids, if the steroid treatment is working, 2-3 months later now, I'll see a difference. I'll see an increase in FEV1, let's say, to 40%, just to give you an example. So those are the three basic reasons to do pulmonary function tests. Diagnose the type of disease, assess the disease severity, and then we said pre-surgical evaluation of lung function. Please, I'll say this later too, but you have to know this, especially with patients that you presume that have some chronic lung disease, especially chronic obstructive lung disease. Please, you have to document that they really have an obstructive disease that's consistent with chronic obstructive lung disease with the pulmonary function tests. One of the things that they've asked on the boards is, well, you think that this patient has COPD, how do you diagnose this patient? This patient has been coming to your clinic for years now. Nobody has documented that this patient has COPD. How do we document that? The answer is we do PFTs, and what do I find on the PFTs? A pattern consistent with COPD. It's not it's not pathognomonic, but it's consistent with it, and we're going to talk about this in a little bit. So when we do pulmonary function tests, when you do full pulmonary function tests, you get different numbers. And on the boards, they may give us, 20, 30 of these parameters, and I only want you to look at the ones that we're going to talk about here. So, first of all, we measure lung volumes. Lung volumes are done under static conditions. What I mean by that is it's not dynamic. It's not, you don't compare it to time. I just measure total volume in a patient, total lung capacity, for example. That volume is under static condition. It doesn't tell me what this patient does, how the patient moves air in and out of the lung. That's very important that you understand that. So lung volumes are measured under static conditions, stable condition. I don't know what's going on with time. I don't know how they move air in and out of their lung. I only know if they're normal, increased, or decreased. That's all I know. Because it only allows for measurement of lung volumes under static conditions, the diseases that they really point to are the restrictive lung diseases. So for example, if a patient has silicosis, or let's say they have asbestosis, they get an inflammatory process that affects the lung parenchyma, and as the inflammatory process increases, you get fibrosis and scarring of the lung, and their lung volumes shorten. They get decreased. They get restricted. So if I'm thinking about a restrictive disease, when I measure my lung volumes, they will be decreased. That's what I'm looking for. Now, I said they point towards restrictive diseases. Really, the reason you're doing them is to confirm that this patient has a restrictive disease. But there's also a clinical pearl that I'm going to talk about a little bit later. In patients with obstructive disease, they're usually normal, or they could be elevated. So, for example, they're above normal. Instead of having 100% of predicted, these patients have 120% of predicted of lung volumes. And why does that occur? Because patients with obstructive disease, if you remember, take a patient with asthma, they blow out air and their airways collapse and they trap air into their lung, right, into their lung volumes. So their total lung capacity is increased, their residual volume is increased. This is what we see on the chest x-ray with the flattened diaphragms, the big hyperinflated lungs. So really, lung volumes, when we measure them, I'm really looking for restrictive lung disease, but a lot of times when they're supernormal, above normal, they give us information and they point towards obstructive diseases. I want people to understand that. So let's look at the three most important things. These are the three lung volumes you have to know. And nothing more. We're going to talk about dynamic volumes a little bit later, but when we talk about the pulmonary indices, the pulmonary volumes, I want you to know only three lung volumes, and they're easy to remember. The first one is total lung capacity, or TLC. We have to remember that a little bit later because you're going to see this on the graph, on the table. But total lung capacity is, if I don't know if anybody has looked at patients doing pulmonary function tests, but we make them, sit in a room and they're breathing air, and the tech tells them, breathe in air, breathe in air, breathe in air until they can't breathe anymore. So they take a maximum inspiration. That's what they start off with, taking a maximum inspiration, and you always hear the techs yelling, say, breathe in more, and then once they start to breathe in more and they can't breathe in anymore, when you measure that lung volume in the lung after maximum inspiration, take the deepest inspiration you could take, right? And now I'm measuring lung volume in the lung after a maximum inspiration. That is called total lung capacity. And then, once I have that, what the tech does is it tells the patient to breathe out all the way. Breathe out, breathe out, breathe out, breathe out all the way, expel all the air out of their lungs. And then they do one of a couple of things depending on the way they're doing their pulmonary function test. They either measure the amount of air that they just expelled, or they measure what's left in the lung. And if you think about it, if total lung capacity is the amount of air after maximum inspiration, what's the amount of air that's left in the lung after a maximum expiration, right? So they breathe out all the air out of their lungs, maximum expiration. What's left in the lung is what we can't expel. This is called residual volume. So what's left in the lung after maximum expiration? Residual volume. What did you breathe out? It's called vital capacity. That's all we need to know. Those are the three volumes that we need to know to basically diagnose our pulmonary function tests on the boards. The amount of air in the lung after maximum inspiration, total lung capacity, the amount of air you breathe out of your lung after maximum expiration, that's vital capacity. And what do you have in the lung after maximum expiration? Residual volume. End of story. And look at this. If you go on to this figure now, look at this. They give us all these lung volumes, and we also put the other stuff that they could put there for you and kind of mix you up, inspiratory capacity, tidal volume, and stuff like that. I don't want you to know stuff like that. I told you, I only want you to know these three volumes. So here it is. This is the maximum inspiration here, total lung capacity, right here, right? And then remember what you did? You expelled all the air out of your lung, and what are you left with? The residual volume. And what did you expel out of your lung with a maximum expiration? The vital capacity. Here it is right here. Now, if you remember part one, and sometimes they ask us this in part two, they tell us, well, what's total lung capacity? Well, it's a combination of vital capacity and residual volume, right? That's what they may ask us. People get all concerned, and we're going to talk about this a little bit later, about what's normal. What's normal? What are these volumes? What's normal for these volumes? And the answer is, for all pulmonary function tests, whether we talk about lung volumes or volumes under dynamic conditions, we're going to talk about this a little bit later, or anything else, it's all percent of predicted. Let me give you an example. 80% predicted and above is considered normal. Anything below 80% predicted of the normal population is abnormal. They don't usually give us, things close to normal. They give us something like, for example, 50% of predicted or 40% of predicted. So if they're going to give you numbers that really are low, and to make you understand that you're talking about an abnormal number for total lung capacity or vital capacity or residual volume. They may also tell us, look, it's not 80% of predicted, right, or 50% of predicted, it's 0.50. Well, that's the same thing. They're talking about 0.5 of, total, of 1. That's the maximum. So think about percent of predicted when they're talking about any type of pulmonary function test, and anything above 80% of predicted is considered normal. Anything above 100% of predicted is considered supranormal, right? And that's when we start to think about these things called obstructive lung diseases. So that's number one. That's the first part of the pulmonary function test that we have to know about, the lung volumes under static condition. And then they do a second part of the pulmonary function test. And now, remember when the patient was blowing air out of their lungs? And we said the patient breathes in totally, right? As much as they could breathe in. And now we make them expel all the air out. And that was called vital capacity, right? Well, if you measure vital capacity and you plot it against time, then I get a sense of how this patient moves air in and out of the lung now. Now it's under dynamic conditions. I did it under static conditions before because I got total vital capacity, right? I didn't know how they did it, but I got the total vital capacity. But now I want to know, well, how does this patient move air in and out of the lung? And I take vital capacity, and what I do is I plot it against time. And now it's the same thing, but now it's called forced vital capacity. Whenever you hear anything about forced volumes, forced flow, expiratory flow, all these parameters are measured against time, and they give you a sense of air movement in and out of the lung under dynamic conditions now. They're telling you, how does this patient move air in and out of the lung? And now, if we take a part of vital capacity, which we now just called forced vital capacity, and we take the first second, I'm going to show you that in a little bit, right, of part of vital capacity, it's called forced expiratory volume, 1 second. So that part of vital capacity at 1 second, it's called forced expiratory volume at 1 second. And if you plot that ratio, FEV1, forced expiratory volume at 1 second, over the vital capacity, which we now call forced vital capacity, that ratio, FEV1 over FVC, is the best measure of airflow in the lung. And what does it tell us about which diseases have a problem with getting rid of air out of their lung? The answer is the obstructive diseases. The patient with asthma, the patient with chronic bronchitis, what happens when they blow out air out of their lung, the airways collapse and they trap air in the lung and they can't get rid of it, right? They can't move air in and out of their lungs. So these forced expiratory flows, these forced expiratory volumes are just part of vital capacity, but we measure it against time. And I just told you that ratio of FEV1 over FVC is the best measure of this. And it tells us about obstructive diseases. So let me show you why it's so important, because if you look at here, if you look at the middle graph here, if you look at the middle graph where it's an obstructive pattern, right here, look at this. A patient with an obstructive pattern, they blow air out of their lung. Now look at this. They can't blow air out of their lung. Look, 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 look. Compare this compared to the slope of the curve right here. In a normal patient, look at a normal patient. They blow air out of their lung. They go boom. They expel most of the air right away, right in that first second. A patient with chronic obstructive lung disease, that first 1 second is when the airways collapse, and look what they're doing. Their FEV1 is decreased, you know, and that's the biggest decrease in that 1 second that you see with obstructive disease. That's the biggest decrease in air movement. And when you plot that over FVC, that's the big abnormal ratio that you get. Now you're going to say to me, and they've asked this question on the boards, you're going to say, wait a second, how about restrictive diseases? Look at the one right here, all the way to your right, the restrictive diseases. How about them? Doesn't a patient with pneumoconiosis, don't they have a decreased FEV1? Don't they have a decreased FVC? They do. But both are decreased at the same time, equally. So a patient that has pneumoconiosis, idiopathic pulmonary fibrosis, they have a decrease in FEV1 and FVC in the same ratio. Remember, this is the ratio of FEV1 over FVC. So that relationship is equally decreased. So